I only have 15 minutes. I'm going to move forward to my talk. We're going to talk today about measuring morphine equivalent or pain scores, if you will, in research and the challenges therein. Yeah, okay. I have no disclosures relevant to this talk. So let's talk about the talk. Pain, as you all know, is very subjective, right? And so it's not as easy as saying, well, this individual required 4 milligrams of morphine, that guy required 2 milligrams of morphine, and therefore whatever we did, cut the pain in half. It doesn't work that way at all. Pain and the perception of pain and the expression of pain are impacted by a multitude of psychosocial factors, not the least of which are emotion. You can imagine we've all had headaches. The headache feels substantially worse if you're emotionally distraught, whereas you wake up with a headache. Fatigue, I think most of the people in this webinar are either surgeons or healthcare providers of one nature or another, and we've all felt extreme fatigue. And little body aches all of a sudden become pretty significant when you're really tired. Maturity understanding. I've got two beautiful little girls. I have a 10-year-old and a 12-year-old. And even when they were younger still, their understanding of pain and their ability to put up with pain was very, very different. Daddy, I have an ouchie, and it was like the biggest thing on the planet, when in fact it was a hangnail, and how that changes. And we've all seen patients who have differing levels of maturity, and we've seen patients who regress following injury, and their expression of pain and their experience of pain is very, very different than someone who has, say, chronic cancer and unfortunately has learned to live with pain. And we can see the other factors as well. Expectation really matters. And that's where we can come in and quite significantly impact someone's pain. When I tell someone you have broken ribs and you're going to feel pain for the next 6 to 8 weeks, it'll be worst for the first month, and then it'll kind of taper off. And I put things in perspective. Magically, things get better. But if I say to them, I really think you'll be better in the next 2 or 3 days, they're not going to want to go home on day number 4. They would have expected things to get better in the next 2 or 3 days. The same is true of hernia surgery, same is true of any kind of surgery where we know what the anticipated pain will be. And if we can manage that expectation, magically the pain gets better, even though we haven't treated the pain with pharmacotherapy at all. And as I'm bringing these points up, now start thinking about a research design where one of your endpoints may be morphine equivalent need or pain scores, and how I'm able to very easily impact that endpoint without pharmacotherapy, without surgical therapy, but in fact by psychosocial therapy. And how do you now equilibrate that across the spectrum? Maybe my bedside manner is worse than Pieracci's. Pieracci's a nicer guy, and his patients feel less pain because he spends time with them, whereas I don't. Does that mean the interventions are different? As well, it's far easier to mitigate pain or stop pain than break pain. So maybe I like to give my patients some Tylenol and perhaps celecoxib, which I do, preoperatively before I lay incision down. And those patients are expected to have far less pain postoperatively. Welcome to the world of ERAS protocols. And now things that can impact your morphine score if you only measure it post facto, not preoperatively. One of the biggest challenges that we had with the non-flail study was my hospital is exceptionally aggressive with local blocks. We are all about the paravertebral catheter and ropivacaine. Other hospitals were not, and Fred and I had to have a lot of conversations on, I want to participate, but I don't want to screw up your data by doing so, because frankly, I really think my hospital is better than your hospital. And how do you now account for morphine equivalent needs when I'm using modalities that you may not be using? Oops. Okay, just a little brief, very quick thing on pain physiology. As you probably remember, I am hitting way too many buttons. 1 second, here we go. As you probably remember, pain goes up different fibers. They're the alpha fast fibers and the C fibers that are slow acting. You stub your toe, it lingers for a long time. Goes up to the spinal thalamic tract of the spinal cord where it's transduced, goes up again to the brain where it's transduced. But in the brain, there are other factors that weigh in on the pain pathway and modulate that pain, many of which we've talked about: cultural expectations, just expectations at the bedside from what your doctor told you, maturity level, fatigue, emotion. That's where things come in, and your perception of pain will be very different, and your expression of pain will be very different as well. I will also say if pain is not treated appropriately up front and you have ongoing stimulus of pain, then those fibers become hypersensitive, so that what would not have been a noxious stimulus will become a noxious stimulus. And now your pain needs, your pain medication needs go up because you become hyperesthetic or you have chronic pain, frequently seen in people who have lost a limb and now have ongoing phantom pain when probably their pain wasn't treated upfront adequately with like a block or gabapentin, some sort of a modulating agent. Okay. How do you go about assessing pain? So with that in mind, with all that variability in mind between age, gender, cultural expectations, so on and so forth, there's a bunch of tools that are out there. I only put about 3 or 4 up here, more for examples than to tell you any one is better than the other. The CPOT score is a very commonly used score in the intensive care unit. It's really designed for the ICU patient, and it takes into account things like facial expression, body movement, muscle tone, and then if you're intubated, it takes into account an additional factor of how compliant are you with the ventilator. The idea being that if you're in a ton of pain, you're going to buck the vent quite a bit. The Wong-Baker or the FACES score is obviously very commonly used. I think almost all of us are at least familiar with this qualitatively, if not quantitatively. When my kids were really young, I actually did a bunch of experiments on them myself. I was like, hey, how do you feel? And they really do use that. They can use that as a means to express their pain and discomfort when they were sick with a cold or something like that. And that's really designed for kids. It starts from the smiley face, which is a 0, all the way to the crying, very severely frowny face, which is a 10. And then there's the altered mental status or behavioral pain scale, which is kind of an observational scale, looking at how someone's behaving and trying to quantify that into pain, oftentimes used for people who are brain altered either due to underlying psychiatric disease or some sort of a substance that they've taken. So different ways you can assess pain. And when you look at a paper, you need to kind of be familiar at least with the scale that was used and make sure that when you're designing a study, everyone's using the same scale across the spectrum. This slide is actually the meat of my talk. I want to spend a few minutes on this thing because when we talk about measuring morphine need, that's exactly what we're going to measure. We're going to ask the nurses, or we're going to ask the person who's collecting the data to fill out a form. And the form is going to say, well, how much narcotic did this person get? And you can put it through a calculator to get it to morphine equivalent doses, whether it's oxycodone, fentanyl, dilaudid, whatever the issue may be. But what you have to take into account is how likely is it that the nurse treated the pain in the first place? So let's talk about that for a second. This is an article we wrote many years ago. One of my great dear friends, John Messing, who's a nurse practitioner by training and helped me start the trauma center at GW, came up with this basically. And the idea was this. At GW back in the day, everybody was on a fentanyl drip. And one of the first things I did when I got to GW is I killed the practice of opioid infusions. Nobody at GW is on an opioid infusion, period. Not even fentanyl at 10 mics per minute, nothing. So we decided to go to PRN dosing as a way to liberate people off the ventilator. And then kind of what we realized was, wait a second, people really aren't getting pain medicine very commonly, but my goodness, a lot of people are on propofol lately in the ICU. And we went to the nurse and said, tell us about your workflow. And here's what it took for a nurse to go get 50 of fentanyl from the Pyxis when it was a 50 fentanyl Q1 PRN type of thing, right? Or one of dilaudid Q1 PRN. The nurse had to go into the computer, activate the order, go to the Pyxis with a colleague, open the drawer, count it out, draw the medication he or she needed, go back to the bedside. If you put 50 of fentanyl, the vial has 100 in it. So they would give 50 to the patient, they'd have 50 left over. Go find another colleague, go back and waste it, and have a witness attest to the waste and then document it. Well, that's just one time you have to give that patient drug. Nurse has a lot of things to do in her life, not going to do it. And so what we realized is in our attempt to decrease opioid use, what had resulted is an increase in sedation need. Now, in a research study, that would come off as, hey, this is a really good thing. We have decreased opioid use. Fantastic. In fact, we were treating pain with sedation, i.e. propofol. Major problem. That then led to this effort, which we published in this article, which was the Authorized Agent-Controlled Analgesia, AACA. Think of it as nurse-controlled analgesia, NCA. So when the patient can't push the PCA button, the nurse is now allowed to push it for them. Whoa. What that resulted in was an increase in narcotic use and a decrease in sedation. So in a paper, that's a really bad thing. All of a sudden, everyone's pain score got worse. Of course, it's the same human being that's always been there. It's just that in this instance, we finally started treating their pain with actual pain medications. So the point of this story is workflow matters, and workflow will impact on your data collection if if morphine as an endpoint of pain is what you're assessing for your research study. So you have to make sure that everyone's workflow is uniform, and that way you're comparing apples to apples. If I have an AACA system and you have a PRN system, I guarantee you my patients are going to get more pain medication than your patients. And because they can't say ow, intubated in the ICU, you might perceive that to mean my patients are doing worse than yours, when in fact, they're probably doing better than yours because I'm treating pain with pain medications, you're treating pain with propofol. So that gets to the nursing workflow, that gets to the questions about sedation versus pain relief, and then of course, multimodality therapy. So we're talking about morphine equivalent doses, but what about everything else? I already alluded to the paravertebral catheters that we use at GW. We're about to start doing other crazy stuff like scalene blocks and the serratus anterior blocks and other regional blocks. As I said, my anesthesiologists are all about regional blocks. What about things such as Tylenol? Do you have Oframev in your hospital? That's going to factor quite a bit. Gabapentin, NSAIDs, lidocaine drips, ketamine drips, everything else that we know is opioid sparing, yet is not commonly available. And it becomes very hard to statistically adjust for every single one of these variables. So at some level, I think Fred Pieracci designed his study exceptionally well because he was able to a very, very large degree, make the treatment of pain uniform. There were certain things I could not do at GW that I do for other patients outside of the protocol. And in doing so, try to kind of level the playing field. But of course, that still leaves behind expectation management and culture. What does your patient expect when they show up in terms of pain relief? How are you able to modulate that expectation? And what is the inherent culture? And we know that certain cultures express pain far more overtly than other cultures. And that's going to result in the nurses taking action. They're going to say, gosh, this person is in bed complaining of severe pain. They appear highly uncomfortable. I'm going to go ahead and dose drug on the PRN prescription, on the PRN MAR, whereas this other individual may be quite stoic, sits there, and the nurse is going to be less apt to treat pain unless something overt occurs. So you can try to make things about as uniform as possible, but it is quite difficult to account for all of these various factors. And so when you read a paper, you kind of have to look at it a little bit with a jaded eye when it comes to pain relief as a sole endpoint. So I kind of finish off by telling you guys the only thing that's absolute about pain is that it exists. And we all know pain exists. But the problem is both the perception of pain by me as the patient, as well as my expression of pain to you as the provider are highly, highly variable. And that can vary based on a number of factors that are very difficult to account for statistically in a study design. And so if you just look at narcotic need as your sole endpoint without factoring in all these other variables, you probably will end up walking away with an erroneous conclusion. Hence the difficulty in looking at pain as an endpoint. I'll stop right there. I think I met my time limit, and I'll just end as always by thanking Tom, Sarah, and the entire CWIS community for the opportunity to speak to you guys. It is an absolute pleasure to just simply see a few friendly faces on the webinar.